Transportation Studies acknowledges the Gabrielino Tongva peoples as the traditional land caretakers of Tovangar, where the UCLA campus lies today. We also recognize that the UCLA Lake Arrowhead Conference Center sits on the territory and ancestral land of the San Manuel Band of Mission Indians, the Uhaviatam people. We would like to thank the sponsors of the 2020 UCLA Arrowhead Symposium online series. Their support enables us to bring you today's program. In particular, we'd like to thank Cambridge Systematics for their sponsorship support for this session. This is an interactive session. To participate in this session, use Zoom's built-in chat, Q&A, and raise hand features.
Greetings, my name is Lise Mendes and I'll be serving as the MC for today's session, which is Mobility for Vulnerable Populations during COVID-19. The COVID-19 crisis disproportionately impacts the most vulnerable in our society, including to their mobility. Knowing how the pandemic touches on and shapes the mobility of these vulnerable populations can inform government and community response. And today we'll have a panel of people who will be talking about these issues. First up, I'd like to introduce our first speaker, Evelyn Blumenberg, who will be doing a presentation. Evelyn Blumenberg is a director of the Lewis Center for Regional Policy Studies and an urban planning professor within the Luskin School of Public Affairs. Her research examines the effects of urban structure on economic outcomes for low-wage workers and on the role of planning and policy in shaping the spatial structure of cities. Evelyn, I'll hand it over to you.
Thanks, Lise, very much. It's a pleasure to be here this afternoon to speak on this topic. I'm only sorry that we can't be doing this conference in person. For those of you who were at this morning's panel session, it's a little bit hard to follow. That morning panel set a very important context for the remaining session of the conference. So I want to thank all the participants and those who participated in the chat. I thought it was all very, very helpful. This afternoon, I'm going to make some general comments about mobility for vulnerable population groups, focusing specifically, as the title of the session suggests, focusing specifically on what's going on around this particular sort of health crisis. I'm going to talk, sort of draw a little bit from my own research as well as the research of others, and then I'm going to turn it over to the two other panelists to talk on much more specific sort of topics. I'm going to make 3 points in my 15 minutes. So first, the systemic inequities that produced mobility disparities prior to the COVID-19 pandemic are responsible for mobility disparities during this crisis. Second, that the COVID-19 crisis has magnified some mobility disparities, and it also has produced additional disparities. And then finally, I guess just a reminder that the data on economic recovery suggests that these disparities will linger well beyond the immediate health crisis, and we should prepare for that. Well, it shouldn't come as a surprise that the pre-COVID mobility vulnerable continue to be vulnerable during the COVID-19 crisis. For those of you who have heard me speak before, this slide is not going to come as a surprise. I have argued repeatedly that in cities built around automobiles, households without access to cars are at a significant disadvantage. It's always hard to make this argument in a audience of urban and transportation planners who are focused on building sustainable communities, but the data don't lie. So with any given travel time, cars provide greater access to opportunities than public transit and also walking and biking. So this slide focuses specifically on access to employment opportunities, so access to jobs. It shows the ratio of jobs accessible in 60 minutes by automobile relative to public transit in 10, sort of relatively transit-rich US metropolitan areas. So in Los Angeles, all the way on the right, cars allow access to 13 times as many jobs.
Sorry, this is Whitney. It doesn't look like your slides are in full screen in the presentation view.
Huh. Thank you for telling me. And I don't know if they are on my screen. Let's see.
You can click that little presenter button next to the Zoom at the bottom of your screen. The bottom right.
Hold on. Bottom right.
Bottom right next to
presenter
the
view. Is this better?
No, you're in the.
Oh dear.
Okay, click on in slideshow. And then click on the right next to the Zoom, right there. Yeah. Well, you're right at it, right at the Zoom window, where you're zooming the percentage at the bottom right. Here, I'll present for you. How about that?
Well, show presenter view. Is that it?
Yes.
That's I believe you have two monitors set up.
I have two monitors.
Yeah, and we're probably seeing the other one. So Whitney, I think if you have the backup slides, you can just present for Evie.
Although I added a slide, but okay. You want to present for me?
Yeah, I'll go ahead and present for you.
Let me know when you're ready. I've stopped sharing. Sorry, everybody.
There we go.
These look familiar.
This is
Okay,
where you are.
perfect. Next, keep on going. So go back. Okay, so you get the gist that there are auto and sort of transit disparities. So I had showed, I thought previously on the right, sort of is Los Angeles, so 13 times sort of or access to jobs than public transit. This slide shows New York, so still, heavily transit sort of rich metropolitan area. 4 times as much access by car than transit. So next slide. And next slide. And 6 times as many in San Francisco.
We're not clicking here. There we go.
Okay, 6 times as many in San Francisco. Okay, next slide. Okay. So low-income and non-white households are less likely to have cars than white households. And so that's what you see on this slide. It's showing data from the National Household Travel Survey in 2017. And you can see that, the percentage of zero vehicle households among households with income less than $25,000, more than a quarter do not have cars. Almost a quarter of Black households are zero vehicle households sort of as well. Next slide. So I agree with what Gil Penalosa said this morning, that the COVID crisis has magnified some mobility disparities that existed before this crisis, but also produced additional disparities. Next slide. So low-income and not, as we know, low-income and non-white workers are least likely to be able to telework, and consequently, they're most likely to travel to their jobs. Next slide. Okay, so these are data from the American Time Use Survey, and so it's the ability to telework by income and race and ethnicity. So on the left of this side, among workers in the top quartile in terms of earnings, 62% are able to telework, compared to only 9% among workers in the bottom quartile. On the right of this graph, you can see the data by race and ethnicity, and look at the disparities there as well in the ability to telework. Next slide. So in addition, low-income and non-white workers are most likely to have been laid off due to COVID-19. Next slide. So these are data from the Pew Research Center. They focus on whether the respondent themselves or someone in their household lost a job due to COVID-19. Again, income on the left, race and ethnicity on the right. About a third of higher income households, either the respondent or someone in their household lost a job, compared to only 14% among upper income households. And the racial and ethnic disparities are large as well, with Hispanic and Black respondents being more likely to have lost a job, or someone in their family has lost a job. Next slide. So those without cars remain at a disadvantage. So they still face the same kinds of sort of pre-COVID disparities in access to opportunities by mode, except that these are compounded for many by the need to search for jobs. It's very difficult to search for jobs, make multiple sort of trips on public transit. So cars are better suited to that. And then layered on that are health or health fears related to public transit use, which I think is going to be the subject of one of the future sort of panels in this series. Next. So in addition to sort of facilitating travel for work, the current health crisis has elevated cars as the means to accessing other types of services, goods, and activities. Some of you who know me will know that I've been a bit obsessed about collecting articles and images of the role of the car as part of this pandemic. And so I have created a slide with multiple images that show this. So next slide. So the car is part of drive-through COVID testing. Next. The car is part of gaining access to donated food. Next. The car is part of all the drive-through food. This is the image of Starbucks, but certainly lots of drive-through food options. Next. Employment, so, you know, cars as sort of the growing sort of delivery occupations. Next. Cars as workspace. Next. Cars as the means to access Wi-Fi. Next. Cars as part of worship, homeless housing, and then finally, cars as a conduit for sort of entertainment. And I think I've just scratched the surface on the use of cars in the midst of this pandemic. Next slide. At the same time, economic hardship related to this crisis may make it difficult for households to to keep automobiles, cutting them off from these and the access they bring. or they may put a squeeze on other household expenses given the high costs of owning and operating a vehicle. Next slide. But so far, the data suggests otherwise, at least on the auto debt and delinquency side of things. So these are national data from Experian showing auto loan change in auto loans ever delinquent per consumer from January to June. And you can see a slight decline, at least in two of those categories over this period. Although it's not on the slide, but the decline is is less for auto loans than other types of loans. And then certainly you can see the bullet point on the right. Part of what we're not seeing here is that these data run through June, and household budgets were amplified by the economic stimulus. So next slide.
I want to give a 3-minute warning.
Okay, perfect. So the next slide shows, this was a graph that was in the New York Times sort of last week, which is the change in median checking account balance from January through August. And so you can see the big increase, sort of through July, the steep drop off in sort of July. So the verdict is still out on auto loans and delinquencies. And we have a current project looking at racial disparities in auto loans and delinquencies related to this COVID crisis. So more on this in a future talk. Next slide. So transit use remains lower than in the pre-COVID period. I think many of us know this. Next slide. This is just one example of these data. So this is change in US Apple routing requests by mode since January 2020. And the red line is as public transit. You can see it's transit use, at least according to these data and others, are not back up to where they were at the beginning of the calendar year. Next slide. And transit ridership, particularly bus ridership, is disproportionately low income. And that's what you see back to data from the National Household Travel Survey. Bus trips are on the left by income, and over half of bus trips are taken by individuals who live in households with incomes of less than $25,000. Next slide. And so now transit riders are poorer, and a greater share are people of color for all of the reasons that I've suggested before, sort of who's working and who has and does not have access to an automobile. And so this is from a survey of transit app users. And so you can see the change in the composition of transit riders during this pandemic. Next slide. So reduced transit service due to lost revenue is, from the transit agency's perspective, is disproportionately going to hurt low-income and non-white travelers. And these are two recent articles, one from the New York Times, one from the LA Times, that basically highlight just this point. Next slide. And so this is, I had one more slide on here, which we're doing some work, which is not included in this deck that Whitney has, which we're doing some work on COVID and safe streets. So in addition to some of the comments that were made this morning about racial disparities in sort of police stops and crashes with pedestrians and cyclists, there are also racial disparities in the ability to be socially distanced in public space. And so we're doing some work on that here in Los Angeles as well. And then my last slide is that this slide shows employment to population ratio by race and ethnicity from 2007 to 2018. It shows racial and ethnic disparities in employment ratios throughout this period. The graph also shows the big decline in employment ratios during and immediately after the Great Recession. And finally, the purpose of this slide is to underscore the long climb back to recovery. This is going to be true for the economy, It's going to be true for sort of low-wage workers, and it's certainly going to be true for transportation as well. So that's it from me. And I'm going to pass the torch. I'm going to pass the torch to Catherine Chen. You know, a lot of us are doctors, and Catherine is a doctor that can write prescriptions. She is a physician at UCLA Health. She's also a postdoctoral fellow with the National Clinician Scholars Program. So I'm going to turn things over to Catherine.
Evie, thank you so much for your kind introduction, and thank you all for your attention today. As Evie mentioned, I am a doctor. I'm a primary care physician. I'm also a public health researcher, and my research focuses on studying ways in which housing, transportation, and our neighborhood context can shape health disparities or conversely promote health equity. And today I'll be sharing work from a literature review and white paper I worked on this summer together with a team from the UCLA Schools of Public Health, Medicine, and Public Affairs, as well as from Cedars-Sinai Medical Center. So we know that in a pre-COVID world, transportation is critically important for access to healthcare. Nearly 6 million Americans delay care each year due to transportation issues. Enter COVID. As of July, nearly half of US adults had delayed or not received medical care because of the pandemic. And this is reflected in a dramatic drop in the volume of clinic visits at the beginning of the pandemic. With time, this has recovered somewhat, but not quite to baseline. And we have seen that the rise of telehealth or virtual visits has filled in some, but not all of these gaps. And it's not just clinic visits. People seem to be avoiding the hospital too. And all of this is concerning because missed care can have really serious clinical consequences. For example, data from New York City showed that during that period when hospitalizations were at their nadir, there was a huge spike in out-of-hospital cardiac arrests. Now, cardiac arrests can be preventable if people get appropriate cardiology care in clinic and if they go to the hospital when they have chest pain. When people have cardiac arrests outside of the hospital, they're more likely to die from them, and the data reflect that. So we wanted to understand with this white paper how transportation factored into these changes we were seeing during the COVID pandemic. And the motivating question for this work was, how has COVID-19 impacted transportation to non-COVID related healthcare? Here's a brief overview of my talk. And I'll jump right into it with the general changes in transportation to care. So I'm not going to belabor this point. I know that a lot of other speakers during this conference will be addressing how COVID has directly impacted transportation systems. But I did want to highlight, relevant to transportation to care, this statistic about paratransit, showing that paratransit use dropped by as much as 80% at the beginning of the pandemic. And as of July, it had recovered to about 50% of typical use. So still way down. But perhaps it's worth a little bit of a closer look at some of these indirect changes in how people travel to care. So we know that COVID has caused many people to lose their jobs, as Evie mentioned. And because we rely so heavily on employer-sponsored health insurance, many of these people will also have lost their access to health insurance. We also know that many people are moving residences during the pandemic, especially, for example, our college students. And both of these factors will change the choices people have regarding whether they can afford to seek healthcare and where they go if they do need it. Additionally, in response to those reduced visit volumes in clinic that I mentioned earlier, some healthcare facilities have reduced their hours and others have closed entirely. And this is especially problematic that this is happening in greater numbers among the community clinics that serve as our safety net for healthcare. And this further restricts people's choices about where they can travel to get care. This may result in longer trip distances, for example. And then finally, some people have been able to skip a trip to the doctor's office because of federal rule changes that have made it easier for doctors to get paid for delivering care virtually or via telehealth. And actually, the CARES Act provided federal funding to try to increase clinicians' ability to offer telehealth, to provide, that additional technical support on the physician side, but that funding has not focused as much directly on the patient side of broadband access, which somebody brought up in the chat, and I think that's a really important point we should talk some more about. I did want to pause briefly here to define two important terms. So the two main ways in which people receive subsidized rides to healthcare are paratransit and non-emergency medical transportation, which we abbreviate NEMT. So paratransit, which I already mentioned, is paid for by our local transit agencies, arranged directly by the rider, and requires proof of some sort of physical or mental disability or limitation of some kind. Meanwhile, NEMT is paid for by insurers, health insurers. So that includes Medicaid, although some states have obtained waivers or exemptions to prevent them from having to cover that service. And then a minority of Medicare plans cover NEMT. Virtually no private health insurance plans cover it. Who it's actually arranged by is highly variable depending on the plan and the state that you're in. Sometimes it's directly through the insurer. Sometimes there's an outside broker who manages these things. So highly variable again. And then most NEMT plans benefits require documentation of a medical or physical limitation. But actually increasingly, there are some plans like the Medi-Cal program in California, which offer services to people even without documentation of a medical or physical limitation. Strictly the patient needs to say, I need help getting to my doctor's office. And that's been hugely instrumental for my patients who I take care of in Los Angeles. Just want to highlight that this is big business. Paratransit accounts for 12% of transit budgets, while NEMT costs Medicaid about $3 billion a year to the federal budget. So the bulk of our white paper, with that introduction in mind, wanted to focus on how specific types of healthcare might have been affected during the pandemic from a transportation standpoint. And so our strategy here was to first identify a list of healthcare needs that were either overrepresented among people with transportation challenges and or in which transportation interventions were previously shown to be cost effective or cost saving. And then for each of those healthcare needs, we reviewed modal patterns, transportation challenges, and data on the impact of COVID-19. And the spoiler is that there was not a lot of concrete data about those specific conditions. One of our conclusions was that there's a need for more research. We came up with this list of 7 healthcare needs. So I'll just pause for a second. And for the sake of brevity for this talk, I'm going to highlight findings specifically related to our first healthcare need, dialysis for end-stage kidney disease, but you're welcome to review our white paper for details on the rest. So first, what is dialysis? Dialysis is the use of a machine to filter the blood, to balance our blood chemistry and remove toxins and excess fluid from the blood. People with end-stage kidney disease rely on dialysis to stay alive when their kidneys are no longer able to perform these functions. Most people on dialysis, about 2/3 of them, rely on something called in-center hemodialysis, which means that they travel to and from a dialysis facility 3 to 4 times a week for a total of 6 to 8 trips per week to undergo this dialysis procedure, which is extremely exhausting. And unlike other types of healthcare, we can't yet deliver dialysis over the phone during the pandemic. And if people miss their dialysis sessions, they can have serious and even life-threatening consequences. So how do these patients get to the care they need? Well, it's not easy, even before the pandemic. Based on data from the Transportation Review Board, it turns out that only about 1/4 of patients who require dialysis drive themselves to that dialysis. Most of them rely on rides from others, with about 40% using paratransit and about 1/5 getting rides from friends and family. There's also overwhelming consensus from social workers who coordinate care for these patients that public transit is a big issue with quality dialysis, with patients receiving quality dialysis. And in particular, public transit issues contribute to shortened and skipped dialysis sessions. We have stories of patients who have voluntarily cut short their dialysis session because they didn't want to miss their ride. So this is very concerning. And during COVID, when public transit service is cut back even further, and when patients are leery, perhaps, of sharing air with others in a car, all of these patients who aren't able to drive themselves, who are already at disproportionate burden from a transportation standpoint, may be in even a bigger bind during the pandemic. And the threat, again, of COVID is especially concerning in this population because end-stage renal disease is considered an immunocompromising condition. So that means these people are at increased risk of COVID complications. So far, some transportation companies and some dialysis facilities have implemented patient pods or clusters to try to reduce transmission risk. And then one other thing that's happened during the pandemic is that there's been an increased push to try to get people onto alternative treatment plans. Actually, before the pandemic, the federal government had a goal to get most people onto in-home dialysis care by the year 2025, We already have the technology, have had it for years. Most patients prefer it. We just haven't been doing that as a routine practice. And so COVID has made this goal even more urgent and appealing. So again, for more details on those other 6 healthcare needs, you'll have to refer to our white paper. But I'm going to highlight now just some important recurring themes that we found throughout all of the healthcare conditions. So the first theme is what lessons can we learn from existing transportation programs and from research on the impact of those existing transportation programs? Well, first, unfortunately, there's not a lot of high quality, rigorous academic research, in part because a lot of the interventions have focused on sort of multi-component programs as opposed to studying specifically transportation interventions in isolation. But the limited research we do have suggests that transportation provision might improve visit show rates. It depends though, because the evidence is mixed depending on which study you look at, and there's not enough to conclusively say one thing or another. Unfortunately, we have pretty much no data about how providing transportation might influence clinical outcomes. So there's perhaps a research need there. And then there is, however, quite compelling evidence from simulation type of studies looking at cost effectiveness and showing that providing transportation to people with most types of healthcare needs, including preventive care, is considered cost saving or cost effective for society at large. And then one last takeaway from the existing literature is that uptake of the transportation interventions offered in these studies was quite low as 3 to 30%, depending on the study. And some of the issues raised by patients in these studies about why they didn't want the services centered on things like affordability, reliability, flexibility. And as a primary care doctor myself, I will be the first to admit to you that despite giving you an appointment time, it's really hard to promise that I will be ready to see you at the existing time, at the scheduled time. So perhaps we need to reform this whole system. And then finally, accessibility. Rear door bus boarding may be helpful for reducing COVID transmission, but we need to make sure that our wheelchair riders can get on, for example. The next theme was that COVID-19 has created new trade-offs for trips to healthcare. From the individual standpoint, individuals must weigh the risk of COVID exposure for a trip out of their home versus their need for healthcare. And from a community standpoint, communities need to weigh the risks of COVID transmission and the externalities of vehicle emissions versus the need for economic support for our transportation programs and community clinics, which we know are struggling financially during the pandemic. These are really hard and complicated decisions, and as a result, a couple of groups such as the CDC have created frameworks and decision tools to try to help people weigh these tough decisions. So this is an example from the CDC. It looks at potential for patient harm based on the type of health service that you're offering and how likely it is that there'll be harm. If you don't provide that service, then you sort of look through how bad COVID is in that community and make a recommendation. But importantly, I want to highlight that asterisk at the bottom, which tells us that basically groups that are most medically vulnerable and those with the biggest barriers to telehealth, which generally includes our most transportation disadvantaged population, should be prioritized for in-person care as needed. Our final theme, perhaps the most important theme, and one that will not surprise anybody after what we've been focusing on this conference, but which bears repeating, is compounding inequity. It is abundantly clear that the same low-income and Black, Indigenous, people of color groups experience the greatest disadvantage in socioeconomic position and transportation, as Evie mentioned, and also, shocker, in health. In both pre-existing conditions and in COVID complication rates. And this is no accident. It is policies put in place by the privileged classes that have embedded the structural racism into the fabric of our society. And these intersecting disparities continually overburden the same communities, meaning that disadvantage is produced and reproduced as these marginalized groups experience greater travel burdens, which result in missed care and later stages of diagnosis, leading to worse health outcomes and widening disparities. So for example, referring back to our patients on dialysis, Black Americans represent 13% of the US population, but 30% of people with end-stage kidney disease requiring dialysis. So how can we move forward from here? We identified sort of guiding principles around access, flexibility, collaboration, and equity, which can help us move to overcome these barriers. First, regarding access. If we recall that the most medically vulnerable patients are least likely to drive themselves, we need to increase access to high quality alternatives, including public transit, paratransit, NEMT, and perhaps things like volunteer driver programs. And to improve that access, we need to increase screening for transportation needs. And that can happen on the transportation side, but also needs to happen in my world, in healthcare. And that is starting to happen, but we are moving slowly and need help connecting people to the existing resources. We also need to make sure that the screening can be done in a COVID safe way. So places, for example, like San Francisco have moved from in-person sort of eligibility evaluations to phone and internet assessments. We also need to work on perhaps expanding eligibility criteria. Think about people who do not qualify for the existing programs. For example, undocumented immigrants who do not qualify for Medicaid or Medicare cannot get into these programs. And then we need to think about improving service quality and capacity. Not just, quality, thinking back to those domains that we talked about as potential barriers to previous transportation intervention uptake. But capacity is important too, because as people have lost their jobs during the pandemic, we've seen increased numbers of enrollment in Medicaid across the country in many states. And as a result, that's a lot of people who might newly become eligible for NEMT. We need to make sure systems can accommodate them. The next guiding principle is flexibility. We need to think about flexibility and scheduling so that when your doctor is running late, perhaps you can have your ride home on demand instead of on a fixed schedule. We need to think about flexibility and use of existing resources. So for example, if our paratransit providers and paramedics are sitting around underemployed, perhaps we can repurpose those vehicles and drivers to deliver vaccines, medications, or food. And we need to think about flexibility and where and how we deliver healthcare. So if telemedicine was one big thing that might obviate the need for a trip to the doctor's office, but we might also think about providing care at community locations like grocery stores and libraries that may be more convenient for patients.
Hi, Catherine. We need to transition over.
Oh, so sorry.
Giving you a time flag.
Okay. All right. The last thing was collaboration. I think that's the theme of this whole talk about me being here as a physician. So I'll skip this slide, and then equity, just reinforcing what everybody else is already highlighting. So with that, I'd like to transition over to Stephen Wong from UC Berkeley. Sorry for going over time.
Hi, everyone. Hopefully you can see this. I'm going to just go into present mode. All right. Thank you so much for having me here. Again, my name is Stephen Wong. I'm a doctoral candidate at the University of California, Berkeley, but I'm also here representing the UC Institute of Transportation Studies. And it is a collaboration across 4 campuses: Berkeley, Davis, Irvine, and UCLA. So I'm happy to be representing all 4 UC campuses here today in this presentation. So let me go ahead and get started. Today, I'll be talking about double the trouble, evacuations during COVID-19. This is the research team. It includes myself, Jacqueline Broder, who's a staff researcher, as well as Dr. Susan Shaheen, who is a professor and PI on this work. So just a brief background on what I'll be talking about with evacuations and COVID-19. So evacuations, large-scale ones, are one of the primary methods to safeguard human life in disasters. Millions of people are ordered to evacuate from Hurricanes Irma, Florence, and Dorian in recent years, as well as 1.1 million people ordered to evacuate from California wildfires between 2017 and 2019. There was also the Oroville Dam crisis in 2017, as well as the Texas, a chemical plant explosion in Texas that required 50,000 people to evacuate. So these are both from natural large-scale hazards as well as man-made hazards. Of course, as we know, we have a current disaster season going on. For those of you in California, you know wildfire season has been particularly bad this year. Hurricane season has also been particularly bad, particularly in the Gulf Coast. And of course, we're going to see a higher intensity and frequency of rainfall, heat waves, and wildfires due to climate change. And so large-scale evacuations are not only going to become more frequent, but also larger. This is exacerbated by increasing land development and populations in high-risk areas. In my dissertation, I identified 3 critical evacuation challenges, which kind of are threaded through a number of different areas, but I wanted to compile it into one location. The first is compliance, persistent non-compliance to mandatory evacuation orders. Second is congestion, which is poor transportation response leading to heavy congestion. And the third, which has only received attention since really Hurricane Katrina, has been ensuring that all populations, especially those most vulnerable, have transportation and shelter via social equity. Of course, with COVID-19 and the recent pandemic, there is now a 4th critical evacuation challenge, which is the need to minimize spread and communicate risks and notify evacuees of these different types of new plans. The other challenge in these types of evacuation situations is that there are a number of strategies that require high contact between different types of people. And a lot of these different types of strategies are also built in order to protect vulnerable populations in disasters. This includes public transit, shared mobility, congregate public shelters, friends and family assistance, and volunteering and recovery assistance. So this really brings us to 3 main points here that I want to go over, which is an ongoing crisis. First, stay-at-home orders and social physical distancing to address COVID-19 directly conflict with evacuation orders that typically rely on high-capacity vehicles and shelters to protect people in disasters. Disasters also could exacerbate the spread of COVID-19 due to the movement and close contact of evacuees, first responders, and volunteers. And finally, and perhaps most critically, is that a lack of COVID-19 and evacuation planning will disproportionately harm preparedness, response, and recovery of Black, Brown, and Indigenous communities. So this is a really critical thing that we need to be thinking about. And this is what really the foundation of this research that we're conducting here at Berkeley. So we decided to develop a playbook or a guidebook for agencies in order to tackle COVID-19 and evacuations. And we thought that actually the best way to do this would be through a variety of different expert interviews across a number of different organizations and areas. And this included 17 experts of 13 organizations represented. We asked about critical challenges, current preparedness efforts, and preliminary strategies for COVID-19 evacuations. Also, a number of these different interviewees were at the executive director or chief levels of their organizations. This is a responsibility mapping of strategies. I don't expect anyone to memorize this, but this is still very helpful, hopefully, for you as I talk through these different types of strategies, and that there is a lead agency or a lead actor involved in these different types of strategy areas like transportation evacuations. They also align with California emergency support functions such as ESF alignments, and so that's also provided here. For most of you probably on this call, you're probably most interested in transportation evacuations, which is that's one of the your lead roles to play here. So I'll be talking about the preliminary results here. And the preliminary results are really types of strategies that are critically urgent over the next 1 to 2 months while these disasters are still going on. So these are strategies that are aimed to be very actionable and very helpful for agencies in terms of combating disasters. I also want to note that these specific strategies were all mentioned by experts and were just rounded out through our conversations with a number of different experts and packaged in an actionable way by the research team. So first is transportation and evacuations, which is led by transportation agencies and uniquely law enforcement, which is something that is specific to California, but could also be across the United States. The first strategy is develop private vehicle evacuation plans, and this is creating plans for private vehicle travel. Cars are one of the best mechanisms in order to reduce COVID-19 exposure in an evacuation, and it's also the primary mode of transportation that people use in order to evacuate. So we do need to still create and bolster these types of plans to decrease congestion, such as through phased evacuation plans or signal priority, and encouraging residents to leave early and quickly. This is to not only decrease demand on the roadways for congestion, but also decrease overall demand for key resources such as food or restrooms. The next is focused less on private vehicle travel and more about public transit, regardless of mode, but to implement standardized COVID-19 protocols. This, of course, should be happening under normal circumstances, but should also be critically thought about during a disaster as well. This includes increasing sanitation, supporting social distancing, mandating mask wearing, and distributing health information that could be provided on these different types of transit vehicles. A couple other ones include implementing COVID-19 mitigation efforts to protect operators, who are often not only vulnerable in their communities, but also in terms of transporting individuals, have to go into a disaster zone, which could be very dangerous for them. So the experts recommended implementing barriers, creating new procedures and protocols such as socially distanced boarding, and using contactless technology systems. Some of these are already being implemented, and that's great. But the key here, again, is that in a disaster scenario where there is an incredible amount of uncertainty going on, that these still need to be primary efforts provided by transportation agencies and law enforcement, as well as with public transit operators. Supplying personal protective equipment to transportation employees, and also leveraging existing information resources, for example, changeable message signs, or using travel information systems such as 511 to provide these notices to evacuees related to COVID-19 or the disaster that is going on. So these are the primary ideas for transportation and evacuations mentioned by experts that really need to be conducted immediately. Now, the next area is care and shelter, which some of you may wonder, well, why does this matter for transportation? Well, in the end, everyone has to go somewhere. And specifically, congregate public shelters are places where people who don't have social connections and those who are often most disadvantaged and vulnerable have to go to in a disaster to receive resources and a place to stay. This is led by public health agencies, social service, as well as CBOs and NGOs. This was an area of critical concern for experts and also represents probably the most drastic changes in how to evacuate people, but specifically in the sheltering area. The first is designate separated and quarantine zones for COVID-19 positive evacuees. This includes building partitions around beds, spacing beds for both positive and negative evacuees, and providing isolated rooms or tents to reduce exposure. Also, pre-shelter screening has to be implemented to check for COVID-19 symptoms, but also for critical care needs, specifically for individuals with disabilities or who have additional healthcare needs to be able to receive that type of care. And also create a protocol for COVID-19 positive evacuees to be directed to quarantine spaces or non-congregate shelters. And what are non-congregate shelters? Well, experts really wanted to focus in on this area. And that's because non-congregate shelters easily divide evacuees and keep them separated such that it reduces COVID-19 exposure. This includes considering hotels, motels, fairgrounds, college dorms, stadiums, peer-to-peer sharing such as Airbnb, but also specifically providing access to transportation for functional needs populations to and from these different types of shelters. Supplying and requiring personal protective equipment, of course, not just spans public transit operators, but also evacuees and volunteers who may not have access to those different types of resources, and again, are often those who are most disadvantaged. And also requiring masks to be worn at all shelter facilities. For emergency management strategies, some of you on the call may be wondering, well, why does this matter for me? Well, in all aspects, transportation is interfacing with emergency management agencies in a disaster. So the first is to engage with public health departments, designating key liaisons for assistance throughout the disaster response, especially for transportation and sheltering. Bolstering supply stockpiles for PPE, which could be distributed to public transit operators, identifying storage facilities, but also designating a lead agency for bulk ordering. And this could be not just the emergency management agency, it actually could be the transportation agency to provide this bulk ordering. But it's critical that there is both local, county, regional, and state level types of resource partnerships going on. And then also adapting the emergency operations center. And this could also be thinking about traffic operations centers, which some of you may be also dealing with currently, which is either abiding by COVID-19 requirements or creating some type of virtual emergency operations center with necessary internet-based technologies and equipment. Also, I want to point out generators is important, considering now we have entered the PSPS, also known as Public Safety Power Shutoff event season here in California. Having power is going to be critical. There's a couple other strategies I want to mention. First is developing online training programs. And this can be led by emergency management agencies or other different types of agencies, but specifically develop it for operators, shelter workers, and volunteers to teach people how to properly move and shelter vulnerable populations in particular. Also show how to reduce COVID-19 exposure and encourage high quality assistance. Next, develop and revisit mutual aid agreements, such as memorandums of understanding, specifically community-based programs, which has been particularly known to help in disadvantaged communities, and revisiting contracts for hygiene equipment, PPE, and paratransit. And of course, continually updating these evacuation and emergency plans. Public communication strategies is something that, while led by emergency management agencies, interface with a number of different agencies, including transportation. So again, this is why I present this here today. That includes standardizing COVID-19 guidelines, particularly between jurisdictions, such as there is a multi-jurisdictional response, such as mask requirements, and providing this messaging of guidelines to the public. It includes thinking about how to change frontline communication systems. Instead of having daily briefs where people are close to each other, have it via smartphones or loudspeakers. And then something that is crucial for everyone, and we've learned this, and this has been part of playbooks for many years now, from the federal government on down, is enhancing public messaging. And a lot of these strategies don't sound new or innovative. They sound really basic and things that should be done already. But the reason why the experts keep bringing it up, because they aren't being done right now. It's developing clear, direct, truthful, and frequent messaging and communication, which has been seen even in the past wildfire season as one of the key obstacles for providing information and communication specific for evacuations. Employing visual aids, graphics, and information delivery in multiple languages at the same time, I want to stress as well as different accessibility formats. And of course, using trusted information providers. Access and functional needs strategies are also critical. Access and functional needs is a unique definition or term used in disasters for individuals who may need additional assistance or resources, and can include a number of different individuals, including individuals with disabilities, low-income individuals. And so they are kind of grouped as an access and functional needs. And there needs to be first identify people with disabilities, for example, so that further assistance can be distributed. And conducting needs assessments prior to a disaster and associated evacuation is also very important. Conducting outreach activities and creating sustained active outreach to disability communities and disability experts. That also includes, I just want to point out, racial equity experts as well in providing these resources to disadvantaged communities. And also protecting vulnerable populations, either enforcing already existing legislation and acts or creating them outright has to happen at a local, state, and federal level if this is going to work. Finally, for public health strategies, which has been really woven throughout this presentation, but just a couple to point out is that hospitals and healthcare facilities have to develop plans to reduce COVID-19 spread and exposure, and also supporting COVID-19 needs and social distancing, including supplying PPE to medical facilities in all disaster phases. So just to round out this presentation, I did want to present just one more minute of something from the August 2020 California wildfires. This was a major wildfire event still actually going on. The August complex fire is still burning. It is over 1 million acres, which is the largest in California history. But during these wildfires, they were concurrent with rolling blackouts, a heat wave, and producing poor air quality. So I just want to mention that as a compounding disasters that are all happening simultaneously. The smoke was increasing vulnerability to COVID-19, and there's been a number of different aspects to these wildfires, including minimal notice and rapid fire spread and confusion, power loss, but still, interestingly, encouraging full evacuations despite COVID-19, which is a good sign because you really can't shelter in place for these really large scale disasters. And just briefly, the main things that really changed during these wildfires and lessons learned was a lot of these sheltering type of strategies, considering the use of non-congregate shelters, encouraging people to stay with friends and family, but also implementing these new shelter protocols, health screenings, extra cleaning, PPE and sanitizer, requiring masks and social distancing with cots spread out in individual tents. So with that, I want to just really give a thought for the future. And this is also just reflecting on this morning's really great panel and presentation. is that during this time of COVID-19, how can we rethink future evacuations to be more equitable, resilient, and safe? And so this work will be coming out in a policy brief available later this week. We weren't able to get it out just in time for today, but they will be available at the UC ITS website. And we'll be developing a COVID-19 evacuation playbook anticipated in December 2020. So if you're interested in receiving that directly from me, please shoot me an email. I'm happy to provide that to you. And with that, I will hand it back to our lovely moderator, and we will move forward with the Q&A session. Thank you so much, everyone.
Thank you, Stephen. So we heard some really important discussions today from Evie on how COVID has affected transportation and access to opportunity and jobs and resources for vulnerable communities. From Catherine, the impact that COVID has had on transportation and access to healthcare. And from Stephen, the ways that we need to rethink about evacuation process with the lessons learned from the pandemic. So now it's time to hear from our attendees. There's instructions in the chat box on how to submit a question, and we have a few lined up. So now I am going to introduce Juan Matute, who's the Deputy Director at UCLA's Institute of Transportation Studies, who will introduce the first question.
Hi, everyone. Just take a moment to look at the Q&A feature where you can upvote questions, comment on them, and also submit your own questions. This is an interactive webinar, and a big part of adapting this format is to be able to interact on camera. So our first question is going to be from Carla Mays from San Francisco.
Good afternoon, and thank you so much for taking my question. This is the cornerstone of the work I've been doing at Berkeley Center for IT and Society, working on COVID-19 equity. My question is to the professor in regards to car-free. Have you been looking at car-free strategies and how it's been, how the damage has been done to BIPOC communities from car-free advocacy, because there's so much things that, when you don't have your own car, but the things that have increased that is decoupling decoupling affordable housing and cars and in that one parking spot, metered parking, freeway lanes that cost, and things when we know that folks are being pushed out further and farther away from transit. And that gentrification displacement has been, been at effect, and that most transit that is high frequency is in Todd areas that are high cost without affordable housing around it. And then when a person does, or a family does get affordable housing, that they don't have that car. The car costs of the parking of a car can be equal to the amount of affordable housing, the cost of the rent. Have you looked at that?
So yes, I guess the short answer is yes. And Carl, I'm not sure I could make the argument any better than you did for the necessity to adopt a set of policies that de-incentivize cars and sort of builds in the costs of automobile ownership to the price of affordable housing, for example, that you talked about.
Well, my question is that these policies have negatively affected BIPOC communities of taking away the ability to have a car, and then the cost. Like here in San Francisco, I can attest, even, personally, living in a BMR unit that does not have a parking spot, and the parking here in downtown San Francisco for that in my building is $500. And in most of the folks that are living in the building now do not have access to safe, being able to get to medical appointments and everything. And then we still have more of these strategies on decoupling cars and car negativity. And the question I had, what was a part of my question, is that there's not a lot of us that are planners, that are BIPOC, that are, and when we bring this up, we're often demonized for, not for loving the car or for making it easier for folks to drive, when we have not made transit better so that we can get rid of the car.
So let me just make a few remarks on this. And I am very familiar with the demonization, because I think that the presentation that I gave this afternoon and others that I've given talking about the benefits of having an automobile for low-income families has rubbed many people in the wrong way. So I think that the big problem is that we expect that low-income and non-white travelers should live without a car for sustainability reasons, when it's higher income. You just saw the data, whether it's higher income households that are much more likely to have an automobile and tend to use that automobile for most of their trips and whatnot, and travel farther. And the question that you asked, so the choice is going to perpetuate disparities in the kinds of outcomes that we care about, and this panel talked about a few of those. The largest body of literature, I would say, has to do with employment and the likelihood of finding and keeping a job. So I've done work in this area, others have done work in this area. And
is it representative though? Is it people that, that are BIPOC? Because I'm from Los Angeles and I live in the Bay Area. My cousins and things that live in South Central Los Angeles, they have that, what they call the bucket, that A to B car that they will go to the police auction and get or whatever. And then that'll be the car that they get. And the issue is that the idea of not being able to have that A to B car, that's not available, and especially during COVID, this is a real challenge. And what I'm saying is there going to be in the next generation of research where we actually start to look at this?
Yeah, well, I hope so. So I definitely hope so. There are policies currently, so you're talking about research, but there are some policies maybe you could, sort of have your cake and eat it too, right? So one of the things that you just mentioned are, sort of older cars. Older cars tend to be gross polluting, driving around low-income, non-white neighborhoods. So there are a set of policies to incentivize among low-income households the purchase of a cleaner, so financial incentives to incentivize the purchase or the use, in the case of car sharing, for example, the use of cleaner fuel vehicles. So there are some efforts to try to navigate that arena on the environmental, as well as on incentivizing having a newer car that might be less polluting, but also more reliable for evacuation, for health appointments, I saw in the chat, for flu shots. People were adding all those reasons, which is really great. I'm going to add them to my list. So there are some efforts on that front as well.
Great. Well, thank you so much for the question. I'll hand it back over to Juan for the next question.
All right, our next question is from close to home. Madeline Brosen from Los Angeles has a question.
Hi, thanks everyone. So I wanted to ask a question to Stephen. I'm going to kind of pick on something from the first panel, and it's kind of a philosophical question a bit. So in kind of positionality. So I know you talked about, you do these expert interviews and they're really important for understanding what agencies are doing, but I wanted to connect that back to some of the demographics that were shown in the first panel about how these, the agencies are really not representative of people in the most need, especially, but just are not representative, period. So I'm just wondering what you think about kind of the positionality about doing these expert interviews, how that might have shaped your research, and maybe not the outcomes I think we saw, but maybe in their order or priority, and just kind of thoughts about how to, we say expert interviews or trying to understand things, how researchers and anyone trying to understand this can do a more inclusive job in kind of getting understanding from people.
Mm-hmm. Thank you. Thank you for that question. And the answer is yes, it is biased, straight up. So thank you for that. And I think it's important to call that out as something in especially particularly expert interviews, because in emergency management, a lot of the people we did talk to are in emergency management, which is somewhat separated from transportation, but actually the representation might be actually worse than in transportation. But I will say as a caveat, we did try to talk specifically with disability experts in particular, since often access and functional needs populations are the ones that are often just completely left out of evacuation plans. And so it's definitely a process, let's put it that way. But I do agree with you that in order to bolster these types of strategies, we need, for example, in-depth qualitative interviewing. We need focus groups. In my own research on evacuations, we focus on online surveying, which is a great tool, but often it does not capture the individuals who are actually being evacuated. And so we often supplement these with focus groups, specifically on vulnerable populations. And the results are actually quite amazing. And you get specific recommendations from these communities that experts would never think of, or planners or engineers would never think of, or as an academic I would never think of, and they're very informative. I will say though, one other challenge is I think there needs to be, if you want to kind of go more philosophical, I think there has to be a shift just within academia, particularly in the disaster field. That specific paper on can we increase equity in using the sharing economy in disasters and evacuations, when I sent that to journal, I got completely torn apart because it was not, quote unquote, quantitative enough. And it didn't accurately reflect a broader population, even though I was focusing very closely on vulnerable populations. So this has to be a broader conversation across academia. So I appreciate the question. And I think it's a really important one, especially from a philosophical standpoint, thinking about this morning's session. Thanks.
Okay, our next question will be from Karina Macias from City of Los Angeles Department of Transportation.
Hi, thanks folks. My name is Karina. I'm working for the City of Los Angeles Department of Transportation. And earlier, when the stay-at-home orders came into effect, we found very similar, or our research demonstrated findings that aligned with what Carla was mentioning about her relatives down in South Central. We noticed that right after the orders, the average daily vehicle miles traveled did not drop as much in census tracts where Black and Brown people live, and they live on lower incomes. And we compared to places with higher incomes. We know that Black and Brown people and other people of color are less likely to have the privilege to work from home, as well as and must continue reporting to work sites to go to work. And they tend to drive farther away for resources like food and things of that nature. So my question was related around, I guess, this hope for the next generation of research on whether there's any research or thought being given to how many people and families in California now feel more dependent of their cars than before, and what interventions may be needed to address their personal health concerns while advancing our climate action and racial equity objectives.
And perhaps each panelist can answer that question in their respective issue area. Catherine, I'll ask you to go first since the other two have already answered questions.
Sure. Thank you for that really, really important question. I'm going to admit I'm coming at this from a little bit of the outsider perspective, where the thing that's at the front of my mind is less about the transportation societal impacts and more about the health side of things, perhaps. But one of the key takeaways from our work this summer was this concept of trade-offs, that this COVID-19 crisis has created a situation where there's really no win-win best case scenario for everything. And sometimes we have to accept some of the perhaps climate threat or COVID transmission risk in order to access the healthcare that we need to stay alive, for example. And so there's going to be really complicated decision making here. And there's a lot of research in psychology showing that it's very hard for individuals to apply this like population level data on how to weigh one thing against the other when thinking about their own self. And so the more we can do probably from transportation and health side of things to help process those things and have this conversation out loud, I think the better. But as far as the car specific standpoint in my clinical practice, at the very least, the place where I am seeing this, so I practice at it was called a federally qualified health center in West Hollywood, which is a publicly funded, federally funded community clinic. We see a lot of patients without insurance, a lot of patients on Medicaid, a lot of patients who have currently or previously experienced homelessness. And we're seeing a lot of patients who are living out of their cars. And so that's a whole separate part of sort of car as survival that was an issue in LA. I think a third of our people, about a third of the population experiencing homelessness are living in their, unsheltered homelessness are living in their cars. And that is at risk of becoming even worse as the pandemic threatens to lead to widespread evictions, because these moratoria that we have from the housing side are not actually going to absolve people of their rent obligations. And so my concern from a healthcare perspective is the things that happen when people live in their cars, where they don't have the easy access to a place to store their medication safely, or with the parking restrictions being lifted and street cleaning back in place, people no longer have a safe place to park and then a safe place to shower and use the bathroom. So that's probably like the thing that's on the front of my mind about how transportation has affected our sort of relationship with cars in regards to my domain. But I think that probably you get a different answer from somebody who is primarily focused on the climate impact, especially from an environmental justice standpoint. I think the conclusion is that it's really, really hard, and I don't pretend to have the answers, but I'm happy and fortunate to be part of the conversation. And thank you for raising that.
Evie, perhaps you can answer next.
So rather than repeat myself, I'm going to take another approach to this. So first, I think as part of Arrowhead, and maybe Wong can weigh in, there are a number of researchers who are doing surveys specifically related to this particular sort of health crisis and how it's shifted travel behavior. So I'm assuming, and I'm not involved in those specific surveys, but I'm assuming someone is going to kind of talk about that. And Juan is nodding his head, I see.
Wednesday afternoon.
Yeah. So, so yes, I mean, it's all pretty new, and there's always a little bit of a lag on the research side. And I got to tell you, it's really helpful to hear your comments about your kind of wish list of research. I think is really helpful. It's helpful to me. So that's one thing. The second thing that I will say is that it's you know, for my purposes, it's important to understand that literature on sort of changes in travel behavior and what it is that people are doing in the midst of this pandemic. But in reality, how people are responding in particular neighborhoods is also going to be a consequence of the kinds of policies and practices that we adopt during this period. And I think we cannot forget that. You raised, you know, the issue like affordable housing, right? So can people choose to live in areas where they can get around on, you know, public transit or by walking? There are some neighborhoods, but the price of housing is so expensive, it's really limiting the ability to choose to select into those neighborhoods. What about transit, right? So I talked a lot about cars, you know, because I think cars are really important. Lots of positive outcomes from having sort of a vehicle. But we know that lots of low income folks, people of color, are using buses. Those are going to be hard hit. We can't blame transit agencies. We're gonna need federal funds to help support public transit so that those communities that are currently reliant on public transit have an option. So that's two. And then I mentioned, and this relates to environmental justice, I think it is really important to clean up cars. A lot of those girls, I mapped this out, you know, a lot of the old sort of vehicles are in low income communities of color. Folks are desperate for an automobile for the reasons that I suggested. At the same time, they're gross polluting. So the air quality is problematic. And so we need to address that, make sure that there are incentives so that folks who really need an automobile, where transit is not an option to get to a job across town, have a clean, reliable vehicle that they can use.
Stephen, over to you.
I don't have too much to add. On the evacuation side, I just have a couple comments. I mean, obviously a car, as I mentioned, the presentation is kind of necessary for survival, particularly in wildfires. So having access to a car or knowing someone with access to a car is going to be critical. And if it is in communities that don't have access to cars, one mechanism or intervention, I guess, as you had kind of posted in your question, is really thinking more about city-assisted evacuation plans. And for those of you on the call, you may not know, but there's pretty much no mandate for evacuation plans anywhere in the United States. And this is a real problem because oftentimes these evacuation plans are the ones that need to have a public transit aspect to it that transports people who do not have access to a vehicle. And oftentimes these lag behind emergency response plans just in general. And we saw that came with deadly consequences during Hurricane Katrina. Ironically, or maybe this makes sense, that New Orleans now has, in my opinion, the best city-assisted evacuation plan now that they have gone through it. And then I also just want to bring up that at least in an evacuation context, particularly in a California context with grid impacts, you know, we're talking about clean vehicles as well. Evelyn mentioned that, having clean vehicles, electric vehicles. But I do want to also point out that there is often a disconnect between resilience and sustainability. They are not necessarily the same things. And having a lot of electrified transportation options, while great for decreasing greenhouse gas emissions on a regular basis, can actually be really bad in disasters. I'm not necessarily advocating here that we shouldn't be thinking about using electric vehicles and other types of clean transportation that can reduce GHG emissions, but that's something that is something to think about. And then one more thing I thought I just had is purchasing of generators in disasters, for example, is a financial burden that most low-income households just cannot afford. And there's been a lot more work recently on asset poor and unbanked populations in disasters, and being unable to afford even just key resources, including generators. So I think there's a lot to be done, and just the evacuation disaster field is definitely needing this research.
Great. I'm going to chime in with a question. Once there's a vaccine, crossing fingers, what does recovery look like for your area of study? What are some of the things that we should have learned from this time that should drive policy changes in your area of study? And what does that mean for the disproportionate impacts that vulnerable populations face? And so I'll start with Catherine again.
Thank you for that important question as well. I think from a healthcare standpoint, the fact that we're seeing this drop in clinic visits we're going to have to sort of understand and spend some time digging through sort of what the clinical consequences of that are, and what amount of that care actually we maybe never needed in the first place, and maybe what number of those trips were not something that we need to prioritize, and how we can focus on delivering the highest volume care to patients while reducing transportation burden at the same time. And so some of that involves things that are outside of the transportation system, like telehealth. There's a lot of things that we can do very effectively over the phone, like checking in on mental health conditions in particular, but even if patients have a blood pressure cuff at home, I can call them and they can tell me how their blood pressure is doing, and I can adjust their medicines. And it's probably a more reliable way to check somebody's blood pressure than when they have taken the bus across 3 transfers to get to my office and it's hot out and they're late and the person at the front desk was rude and their blood pressure is high, and I don't blame them. And maybe I should adjust their medicines based on that sort of setting. So there's positives in this whole telehealth movement that we're seeing that a lot of people in my field are hoping we can sort of keep around after the pandemic for patients who are able to access telehealth. And I should add that telehealth can be done by phone. I do it by phone. So most people these days have a phone. Our homeless patients come in and use the phone in the lobby, and we talk to them on the phone. But even in most of our vulnerable communities, most people have a phone. They might not have internet access. Doctors get paid more currently to do telemedicine visits by internet call with a video than versus by phone. And that is really messed up for a place where we need to probably change our policy for physician reimbursement. If that means that people who would otherwise have access to phone but don't have access to internet for a video visit can't get the healthcare because the physician just wants to be reimbursed at the higher rate. So there's definitely some payment reform issues around telehealth that will change the way we travel to healthcare. But I think also there's an increasing movement for physicians not to get paid per service volume delivered to patients and to get a lump sum to be responsible for the positive health outcomes of our patients. And when we rethink things that way, instead of saying, I need to do lots of visits, lots of volume, then I can take care of that patient as a whole person and think about their health as opposed to my bottom line. And then if their health can be improved by my helping them get transportation to care or get transportation to the physical therapist's office or to healthy food or whatever it is, then I can spend more time doing things that are helpful for patients and not as much focus on just the revenue generation part. And I think that will be part of the big picture legacy, I hope, of this whole COVID thing, because the clinics that relied just on churning volume are the ones that are not able to make it financially right now during the pandemic. So payment reform, I guess, is my overall takeaway.
Thank you very much. Evie?
And I noticed Jacob has a question about newly worsened inequities sort of coming out of this crisis. I feel like the vaccine, even though we're sort of watching the sort of the progress on the vaccine and hoping for a vaccine, I think that unfortunately it will not be a silver bullet. That in a bunch of domains, the crisis is going to have sort of long-term effects, which is kind of why I ended with that last sort of slide. And it's going to produce sort of long-term disparities. So clearly in the economic arena, that then has consequences for individuals and their families, but also has consequences for transit agencies, cities, and all of that. So this crisis, unfortunately, is going to have very long sort of coat tails. I was trying to think. So with respect to transportation, so that's linked. Sort of transportation resources is linked, and so I think that there's going to be long coattails as it has to do with transportation precarity sort of as well. And I think that there are 3 different kinds of responses, and I've touched on these kind of already in my comments. One is thinking about sort of the role of federal relief, which is being discussed certainly a lot in Washington. Both in thinking about workers and families, and then I mentioned sort of agencies and cities as well. So that's kind of one area. The second is I think that we need to do a better job of removing barriers related to cars and driving as they relate to low-income individuals and individuals of color. So for example, this morning we talked about racial bias in sort of policing and stops. What about driver's licensing for undocumented immigrants? We can do it in California, many other states, you can't do it. There are racial disparities in a number of lawsuits around racial disparities and driver's license suspensions for non-driving reasons, right? For not paying court debt. We got to address sort of that. And then there's certainly programs that I've mentioned about sort of providing economic incentives to individuals to purchase vehicles, and those come in many forms. And then the last comment, someone raised this in the chat in this morning's panel, is I think that we have to rethink infrastructure as well. The way it relates to kind of the work that I've been doing is really thinking about sort of sidewalks and the ability to feel safe across a whole variety of dimensions. Only one is whether you can walk on the sidewalk and be socially distant. So again, linking back to the, to police stops, air quality, collisions, and all of that. So really thinking about what that means.
And Stephen.
In terms of recovery, I guess I just want to make at least a point that Black, Brown, and Indigenous communities are the ones that are most adversely affected in disasters, and COVID-19 is just going to add a compounding effect. And specific recovery from disasters is often incredibly unequal. There's been research that says, oh, well, social networks in many of these communities are actually stronger, which helps recovery. But that doesn't necessarily lead to additional governmental resources, which they do need to reconstruct many of those social networks in order to come back. And so in terms of like long-term disparities that will occur, I think it will be in these specific communities that will be an issue. And then also on how businesses return. A disaster on top of COVID-19 will wipe out a significant number of businesses, which then just prevents long-term disaster recovery in these places that have been impacted. And so these are just thoughts to just, I guess, put out there. I do think there are opportunities. My worry, I guess I'm worrying than the opportunities. My worry is that as with disasters, and as I learned in my field, once it's 2 years out, everyone kind of forgets about it, it's thrown away, funding dries up, the research dries up on it. And so we just need to have this conversation continually, especially with COVID-19 pandemics, but also especially in the disaster field. But I think there are some opportunities switching away from public congregate shelters, which can often be not very high quality, honestly, and lack a significant number of resources, and go to a model that provides better resources, provides better social connections, in having these, for example, peer-to-peer sharing of homes, focusing more on friends and family assistance, thinking more about how community-based organizations can interface, for example, with sheltering, and providing just better places for people to stay. No one really wants to stay in a gymnasium. People would much prefer to have their own room after a disaster, and I think this is their opportunity to move in that direction. And I think in a similar way, when we do have a vaccine, thinking about sharing vehicles, for example, because cars are expensive to buy and not everyone is going to be able to buy them, but creating these community-based networks, for example, of sharing vehicles during the evacuation can be, or even using right-sized transit vehicles rather than huge buses that can honestly not go in many disaster locations, particularly in wildfires where it's windy and narrow. And so I think there are opportunities here to just rethink how evacuations work following this pandemic. I do think that the disparities, particularly at those areas that have been impacted, are just going to be exacerbated. But I'm hopeful that we can turn a corner and think more holistically about disasters and that preparedness, response, and recovery process.
Thank you so much, Stephen. And thank you to all three panelists for talking about this very important issue and highlighting the needs for vulnerable populations and the ways that transportation, their needs and the ways that we need to think about moving forward to improve these transportation resources for communities that have been most affected by COVID-19. I want to thank our sponsor, Cambridge Systematics, for this event today and for sponsoring this important conversation, and encourage everyone to please take a look at the schedule and make sure that you continue to participate in these important discussions. The next one, air quality, safety, and the well-being consequences of transportation impacts. October 21st starts at 9:30 a.m. Thank you very much to everyone for participating and attending.
Thanks, everybody. Thanks, Lise.
Thank you.